Welcome back to our Waco Family Medicine Point of Care Ultrasound curriculum. Today, we're going to be talking about abdominal point of care ultrasound and looking at the normal anatomy in this lesson of these organs that sometimes we'll want to be investigating using our ultrasound probes. The probe of choice for most abdominal exams is going to be the curvilinear probe, which is why its nickname is the abdominal probe. It has a wide footprint, it's got good depth penetration, and adequate resolution for most of the structures of the abdomen. However, there may be some times when you want to use a phased array probe, namely because of its smaller footprint. So it's got a smaller point of contact with the chest wall or the stomach, and can navigate around ribs if you're looking at things like the liver or gallbladder or spleen or kidneys that sometimes may be obscured by the thoracic cage. Every now and then as well, the phased array probe gives you some benefits if you're doing a protocol-based scan, meaning that you're ultrasounding multiple organs or across wide areas of the body, such as you might do for an EFAST exam or a rush exam. And we don't want to take the time to switch between different probes or transducers during those exams. And so these are going to be the two main probes that you'll utilize when looking at the abdomen. Patient positioning is similar to other ultrasound exams, meaning that we're generally going to have our patients supine, and we'll be positioned on the right side of the patient, machine on the right side of the patient, with the probe in our right hand for most right hand dominant people. However, every now and then you may want to place your patients in Trendelenburg or reverse Trendelenburg if you're looking for free fluid in the abdomen and the patient is hemodynamically stable and able to tolerate it. The reason for this is that, of course, gravity will bring free fluid closer to the diaphragm into that right pericolic gutter or over the spleen where it makes contact with the diaphragm, or help blood or fluid drain down into the pelvis to increase the sensitivity of each of those positions. And so generally it's going to be supine, but keep in mind that you can manipulate your patient's positioning to better increase the sensitivity of your exams. Optimizing the image for getting an adequate view of abdominal organs can be kind of challenging, and there's a few reasons for that. Let's start off with the basics. First of all, remember that our probe should generally be oriented to the patient's right or cephalad, and that the machine preset for abdomen is generally going to be a good preset for us to use for these exams. The machine settings will often help us identify what we need to without needing a lot of extra manipulation or compensation with our time gain compensation. The depth is going to depend on how deep the structures are that we're trying to visualize, and also according to the patient's anatomy. If this is a patient that has a lot of central obesity or is otherwise sort of malpositioned, we may need to adjust our depth to be able to adequately visualize certain structures. Generally, we want a moderate gain, and that's going to help us to differentiate between solid organs such as the liver or spleen, some of our glandular organs, which can often appear a little bit hyperechoic on exam, and then also those anechoic structures like the deep vessels such as the IVC or the aorta. And being able to differentiate between those relies on us not having our gain too high or too low, so just right in that Goldilocks zone. Generally, you'll want your patients, if you're able to schedule these exams and if you're putting them in your schedule or your template for the clinic in the morning, and instruct your patients to fast before they come in. And the reason for that is because bowel gas, especially active after we eat, can really obscure images. And I've got an example of that here on the right. So here in this image, let me get my pointer out. We've got the liver here on this side, and then what you see here, what looks sort of like a bone or like lung at first glance, because we have this bright hyperechoic line with posterior acoustic shadowing, is actually just a loop of bowel with bowel gas. And just like the lung interface looked in our last module, I hope you can kind of see the similarity here where we've got ultrasound waves that are coming in, contacting air and being scattered, and not getting a good signal behind that reflective and refractive surface of the bowel interface. And this mimics the lung because just like when the ultrasound waves were coming in a lung, hitting the pleural line and being scattered, we kind of see that same sort of shimmery structure here as well. And so if you can have your patients fasting, oftentimes that will optimize your image because you won't have to fight quite as much with the bowel gas. It's going to be present in almost all of your patients at some point. When you do encounter it, By adding a little bit of gentle pressure to your ultrasound transducer, you can sometimes dislodge or displace that bowel gas. And every now and then doing a little jiggle with your ultrasound probe over the skin and the soft tissue can sometimes help that gas to sort of displace over to the left or to the right. And suddenly you'll start to see those deeper structures come into better view. Every now and then, if you're looking at things like the pancreas or trying to take a look at the aorta more superiorly in the abdomen, you might want to consider giving your patients a bolus of water by mouth to fill their stomach with fluid and try to displace any air that may be inside the stomach or foodstuffs that might be inside the stomach, and that will give you a better acoustic window. Conversely, if you're looking at the inferior abdomen, you may need to consider bladder management. So although the bladder is a pelvic structure, it can, be large enough or full enough that it extends into the abdomen, or just according to your own patient's anatomy, it may overlie some of those structures that you're trying to look at in the inferior abdomen or in the pelvis. And in that case, either filling or backfilling the bladder or waiting for the bladder to be filled by giving your patient something to drink and kind of waiting, that can help you visualize those deeper structures as well. We're going to take the next few slides to look through normal abdominal anatomy just to get a familiarity with what most of these organs look like. Let's start off by looking at the liver. So we've already seen a little bit of the liver before, but as a reminder, the liver is a moderately echogenic organ, generally pretty solid in structure. You will see these sort of lacunae of ducts and vessels and vasculature, but generally you're going to see a grayscale image that's kind of in the middle range of our echogenicity. It should be immediately adjacent and inferior to the hyperechoic diaphragm, which we can see here is this bright white curvy line. It should have a smooth contour. You shouldn't really see any irregularities or lumps or bumps along the surface. And it has a relatively homogeneous architecture. We call it sort of a starry sky appearance. And I know we use that term a lot in ultrasound and radiology in general. But it has these small punctate portions of brighter echogenic components and these anechoic components, but generally pretty grayscale. And this is what a normal, healthy liver would look like. Next, we'll take a look at our gallbladder. The gallbladder is normally pretty anterior, and so it's often found by looking in the mid-axillary line, maybe a little bit more laterally or a little bit more medially, and is an anechoic structure with nice smooth contours and thin walls. You'll often see posterior acoustic enhancement, so these ultrasound waves, remember, will pass really easily through the fluid-filled gallbladder and accentuate and look a little bit more hyperechoic just deep to the gallbladder. And so we see a little bit of that here, and then also a little bit of that with the liver over here. You might also see something called edge artifact, which will look sort of like a shadow that comes off the edge of any curved structure that's caused by refraction of those ultrasound beams off to an angle. And then sometimes you'll see other artifacts as well, such as comet tails. But those are the main two I want you to know about. It's a pretty easy structure to identify. Next, let's take a look at what the kidneys look like on ultrasound. So the normal kidney will have a couple of different components that help you visualize it. The first is going to be a hyperechoic hilum, which we can see here right at the renal pelvis. And every now and then you will see an anechoic pelvis or an anechoic ureter connecting. But generally when you start to see that anechoic structure, you need to start thinking about some swelling in the kidney, namely hydronephrosis. In addition to this hyperechoic hilum, we have hypoechoic cortex. And we look at that compared to the echogenicity of the liver or the spleen, whichever one's closer to our kidney. And generally, it's going to be just slightly hypoechoic, and that can represent the fluid that's being filled in those nephrons and starting to drain into the more anechoic pyramids, which we can see a couple examples of. There's one here. When we scan back through again, there's one right there. And so generally we're going to go from hypoechoic to anechoic pyramids, and then those will drain into this fibrous and nerve and vascular structure with lots of fat, which makes the hilum look hyperechoic. The kidney should have a smooth contour, and we'll talk specifically about kind of what to measure in terms of size and when we're concerned about hydronephrosis when we focus on renal ultrasound in a later lesson. Next, we'll take a look at the spleen. The spleen is superior and posterior in the left upper quadrant and generally has an architecture that's pretty similar to the liver. In fact, if it wasn't so much smaller, oftentimes if you didn't know where the probe was on the body, you may confuse the architecture and the appearance of the spleen and think that it actually is the liver. Every now and then it may be a little bit more hyperechoic than the liver in healthy patients, and that's just because of that glandular tissue that often has a hyperechoic appearance. And when you're looking at the spleen, the maximum length that you should measure when you're taking a measurement of the spleen is 11 centimeters. We're not going to talk about the spleen in its own dedicated lecture. I'll save that for more advanced applications or if you do an ultrasound elective with me. So I wanted to include its normal length here as a reference for you in case this is the only chance you have to see an example of the spleen during this curriculum. And then lastly, let's talk about the pancreas and aorta, some of our deeper structures in the abdomen. The pancreas can be a difficult organ to visualize with ultrasound because of its proximity to the bowel and to the stomach, which often contain air and make it a challenging structure to visualize. So these are patients that you might want to consider giving them a fluid bolus by mouth or using an NG tube if they are sedated so that you can visualize the structure a little bit better. The pancreas is normally anterior and visualized in a mid-epigastric view and has a variable echogenicity. So younger patients generally will have a more hypoechoic pancreas, but older patients, it'll often get a little bit more hyperechoic and sometimes become even isoechoic to the liver. And so in this view, we can also see that the anatomy of the pancreas is divided into the head over here, the body, and then more laterally into the tail. And it will often overlie the splenic vein and the superior mesenteric artery. So here is the splenic vein, and this right here is our superior mesenteric artery. I'm going to put on some color so that you can see each of these structures visualized a little bit more readily. So now we have a colorized version of this organ, and we can see the pancreatic head here in purple, the body is yellow, and the tail is this teal color. And I went ahead and highlighted the SMA, which we see here looks sort of like a rising sun, a nice clear structure surrounded by a little fat pad that makes it really unique to visualize and pretty easy to find once you get an adequate view. The SMA comes off of the aorta. It's one of our unpaired branches of the aorta, and the aorta and the IVC sit right above our vertebral body, which we can see here is this echogenic line with posterior acoustic shadowing. And so this view is going to be important when we're looking at our aorta for the AAA screening or just to assess for dissection or any aneurysmal component of the aorta, and being able to identify this vertebral body with an aorta over it, and you may in fact see the pancreas on top of that if you're a savvy ultrasonographer, is going to be able to help you visualize and figure out where you are in the abdomen and get those adequate measurements that you need. So this is a quick lesson, but mainly just to talk about the indications for abdominal ultrasounds, remind you a little bit about the exam technique, image optimization pearls, and then introduce you to the normal anatomy. And over the next few lessons, we are going to be diving into each of these different organs and talking a little bit more about them, the exam technique for getting optimal images, and also looking at some pathology and trying to figure out what ultrasound findings may suggest that there's something going on with our patient that we need to actively manage. We'll see you in the next lesson.